in 1 more minute.
Okay, greetings and welcome everyone. As a monthly initiative, Student Council 2021 is organizing an online continuous medical education talk for the greater benefits of Manipal University Medical College students under the guidance of our Student Council advisor, Prof. Dr. Som. First and foremost, I'd like to welcome Prof. Dr. Manumani, Head of Department of Pediatrics, and Prof. Dr. Som for gracing us with their presence today. So before we start, I would like to announce some ground rules for this CME talk. So please keep all your mobile devices on silent mode. Please refrain from eating in front of the webcam. Please ensure that you are dressed appropriately. Throughout the talk, your microphones will be muted by the host and co-host of the meeting. Please turn on your video to engage and interact with the speaker during the Q&A session. The meeting will be recorded and pictures will be taken for documentation purposes. By attending this meeting, you have given your consent for the recording and picture taking. So now I would like to invite Prof. Dr. Som to say a few words.
Good evening, everybody. Good evening, Professor Mananmani. Thank you for joining us. Definitely welcome Dr. Dinesh for coming and giving us facts about how to become a pediatrician, and after that going to tell us about one of the topic on pediatrics. So definitely he will enlighten us on various aspects of pediatrics, not various aspects, one aspect, but various ways how to become a pediatrician, which I can see quite a few people have joined in. So I guess they are thinking on lines of pediatrics. Dr. Mananmani would be definitely happy to see so many people here. And this, as Varsha mentioned, we have been doing it for last five months, and we have tried to do this so that we can encourage our students to know what are the various options they have after MBBS, because as the thing goes, well, after MBBS, you might have to think of doing something beyond that. Otherwise, you might not be very functional after MBBS. So we have to think of something after MBBS, and this is probably one of the specialties that you can think of. We have covered quite a few specialties. There will be a formal introduction for Dinesh, but I know him from batch 17. That was the first batch I was semester in charge of when I joined in. And that time he was 7 and 8 semester, I think 7th semester. So, and after that, the relationship did not stop there. I have met him a couple of times in KK, and he drove from Likas, I believe, that time. And once he was coming, okay, never mind, he could not make it. he had some incident. So it's really very nice to see Dinesh back here and giving us a talk. It's always makes us feel proud that our student has become something like great. It always like they take a piece of us when they go out, and when they come back big, it's really something that we are very proud of. So apart from that, I welcome everybody who has joined in. Even if you decide later that, oh, I may not take pediatrics, but at least from undergraduate point of view, you will take home another topic that Dinesh is going to tell us on acute respiratory distress in children. So let us all put our hands together and welcome Dinesh. Okay, back to you, Kanchana. Varsha.
Thank you, sir. So it's okay. Right now can I call Mr. Tarma to give an introduction about our speaker today? Tarma.
Thank you, Varsha. Now I would like to introduce our guest speaker of the day, Dr. Dinesh Nair Sudaharan, one of our very own college alumnus of Bachelor of Medicine and Bachelor of Surgery, MBBS in the year 2010. His work experience includes being a medical officer in charge of pediatric house officers in Sabah Women and Children Hospital. In 2017, he became the Pediatric Medical Officers Management Committee member, and now Dr. Dinesh is the NRP 7th edition Malaysian Neonatal National Registry Coordinator for Sabah Women and Children Hospital. He also obtained license and certification Neonatal Resuscitation Program, 6th edition provider and instructor, core trainer, clinical practice guideline management of type 1 diabetes mellitus in children and adolescent, advanced pediatric life support provider and neonatal resuscitation program, 7th edition provider and instructor. He holds membership in member of Royal College of Pediatric and Child Health United Kingdom, Malaysian Medical Council, Malaysian Medical Association, and Malaysian Pediatric Association. So without further ado, let's invite Dr. Dinesh Nair to begin his talk.
Okay, thank you very much for the introduction. Thank you, Prof. Som and organizing committee for inviting me to give this talk. Okay, let me just quickly share my screen first. Okay, can you guys see my screen already? Okay, can see my screen, right? Okay. All right. So today, basically, I'll be talking about two things. One will be an approach to respiratory distress in children, and another talk will be about the route to pediatric specialization. So I think I will start with the approach to respiratory distress first, because that's a little bit longer. So it'll be easier for me to manage my time, and hopefully I get you a little bit more interested in pediatrics and not scare you away by doing this first. Okay. Just to promote a little bit, so this is our Women and Children's Hospital, Likas. It's forever having a double rainbow over it. So I'm going to keep goading you all to come and work in Sabah, because we definitely need more people here. And it's a wonderful place to work, seeing as how I never left since I came here 10 years ago. All right, a little bit of a disclaimer. Some of the pictures and videos you may see in this presentation are actually from my personal collection. These pictures are all being taken with consent from the parents for education purpose, but not for distribution. So please kindly do not share any of the pictures and videos too much. Most of the videos, and I will show you, you will be able to find similar videos and symptoms and signs on YouTube. So it shouldn't be a problem. Now, why the topic of respiratory distress? So basically, when Dr. Som asked me to give this talk and told me pick one topic to talk about, honestly, I didn't know what topic to present. So what I did was during rounds, after I finished, I grabbed two housemaids who, when I told them I wanted to ask them something, they ended up looking like that, extremely scared. So I asked them, what topic do you feel would have been most beneficial to have been given a talk about during medical school, which would have benefited you when you are a houseman now? And the answer they gave me was, boss, when we are on call and patients come in with respiratory distress, we get very nervous and scared and don't know what to do. So I thought this would be a good topic. However, that being said, this is a very, very, very big topic to cover. So what I will do, I will try to go briefly to some common problems and some videos and photos of common signs, okay? Because sometimes reading about signs and symptoms alone will not help you if you have never heard or seen any of it. Because if you don't actually know what it sounds like or looks like, you won't be able to pick it up when you actually examine a patient later on. Okay, so now let's go into the topic per se. Let's look at some definitions first. Whenever we do anything or we study anything related to medical, it's always good to go back to a little bit of basics first. So what exactly is respiratory distress? Respiratory distress is basically the use of compensatory mechanisms to maintain adequate oxygenation and ventilation. So how does the body compensate when you want to maintain oxygenation and ventilation does this with two methods. One, increase the rate of breathing, which results in tachypnea. And number two, to increase the work of breathing, which results in things like recessions and nasal flaring. Okay. Respiratory distress can also be a subjective difficulty in breathing which the patient feels. And some of the features you will find in patients which present with respiratory distress will be tachypnea, dyspnea, nasal flaring, chest wall recessions, head bobbing, added sounds, and sometimes cardiovascular manifestations such as mild tachycardia. Right? Don't worry, I will show you a little bit of videos of all this so you'll get an idea of how they actually look like. Now, this little cartoon here is actually very pertinent in pediatrics, right? The lungs and our heart are very much close friends when it comes to pediatric. A major cause of a cardiac arrest is usually due to a respiratory problem primarily. Now, when you see a child with respiratory distress, usually you will have to grade it. And how do you grade it? You usually grade it in terms of mild, moderate, and severe, based on what we find on examination. Okay? So we'll go into this in a little bit more detail when we go to the different videos. Now, when you have someone who has respiratory distress and it's prolonged, what will end up happening after they get tired is they go into respiratory failure. So this is basically when your compensatory mechanisms fail. Okay? There's a very technical definition to it, but what is more important to us when we see a patient in an acute setting is the clinical definition, which is basically severe respiratory distress with cardiovascular manifestations and central nervous system changes. And what are these changes? For cardiovascular, it's usually a marked tachycardia, or the flip side, bradycardia. Hypotension and CNS changes are usually lethargy, altered mental status, or they can even present with hypoxic seizures. Now, let's talk about how big a problem is it actually. So if you look at this chart, this is actually from the United States. But if you look at any center that manages pediatric patients and you look at their statistics, invariably you will find that the respiratory system cause of admission is usually the highest. So in US, it's about 438,000 hospital stays. Okay? It's quite a significant number. Now, this is a very important slide actually. Kids are not little adults, okay? So most of the time, you can't translate what we learn in adult medicine completely to pediatrics. Children come with their own unique set of differences. They have a different range of normal vital signs at different stages of their ages. They have different common illnesses at different age stages. They have different response of the body to medications, and they have a different anatomy at different ages as well. So let's look at something particularly different when it comes to the respiratory system. Some of the differences in anatomy, which is quite important to know because it predisposes kids to go into respiratory failure quite fast. Now, when you look at their nose, they have a smaller septum and nasal bridge, which causes increased resistance. And younger children are often obligatory nose breathers. So when the nose is blocked, they have a lot of difficulty breathing. Okay? The vocal cords are at a different level, and the larynx is more anterior. Now, this combined with the elasticity and cartilaginous trachea causes the airway to become easily kinked when we don't position it properly. Now, when you go into the chest, the ribs are horizontal, the diaphragm is flatter, the chest wall is less stable, and children tend to use the diaphragm more to breathe. They have a lot less pulmonary reserve, and the accessory muscles are less developed. And you factor in that the heart takes up more space in the thoracic cavity, they have larger abdominal organs, all this pushes up the diaphragm a little bit more. So they have very little space for the chest to expand fully. Now, this is also another very important diagram when it comes to respiratory distress in children. If you look at the airways in a pediatric population, so the top one is an infant and the bottom is an adult. In a normal airway, let's say an infant has an airway of 4 millimeters and an adult of 8 millimeters. Both of them have a little bit of a respiratory tract infection. And the child has, both of them have edema of about 1 millimeter. But when you have an edema of 1 millimeter in a child versus that of an adult, just look at the decrease in the cross-sectional area here. In the infant, it drops by 75%. whereas in the adult, it's less than half. And when you drop the cross-section by 75%, the resistance increases by 16-fold, right? And due to all these differences, a child can quickly go from respiratory distress to respiratory failure and cardiac arrest if you don't recognize the distress early and initiate prompt and appropriate treatment. Okay? So this is where knowing the signs and picking it up early and treating appropriately is very important. Now let's look at some of the common causes. So if you look at this slide, we don't have to go into detail here, but there are a lot of common problems or problems that can cause respiratory distress in an infant. And point to note that it may not just be a respiratory cause. You can get CNS causes, cardiovascular causes, and even other causes like diabetic ketoacidosis, which can cause respiratory distress. Now, this is where medical school comes in play. You need to know the basics of all these different conditions so that you know a little bit of what history to take and what are the key points to pick up to help you come to a diagnosis and treat your patients. Now, let's go into approach to a respiratory distress per se. And this goes for any patient that presents to you acutely. It doesn't matter whether it's respiratory, cardiac, CNS, abdominal system. If you have an acute patient, just go back to what you learned from Sesame Street back in the days when you were younger and watching TV. So Sesame Street taught us how to sing our ABCs. And when we do resuscitation, that's what we go for again. A, B, C, D, E. Okay, this is quite standard. Check the airway, breathing, circulation, disability, and exposure. Now, I won't go into this section per se in detail because this will be taught to you recurrently whenever you do any resuscitation course or when you go into management of acute illnesses. What I'm going to do is I'm going to show you some of the common causes of respiratory distress in children, which commonly we see in our casualties, our clinic kesehatan, and in our ward. I'll give you a little bit of key points to help you come to a diagnosis, and I will show you some of the symptoms and signs that they commonly present with. And I think this will give you a little bit more when you see a patient next time when you're a houseman or a medical officer, it should click that I saw this last time, this is probably my diagnosis. All right, so let's go to the first one. This is extremely common. Croup or viral laryngotracheitis. We usually see this in children aged between 6 months to 3 years old. I say usually, but we can also see it as early as 3 months, and sometimes even up to teenagers can have it, but very rarely. Okay? It's an inflammation of the larynx and the subglottic airway. The patient usually will present to you with a history of some nasal discharge, congestion, which progresses over 12 to 48 hours to fever, hoarseness of voice, and a seal-like barking cough. Okay? As the airway obstruction progresses, you will start developing a stridor. Okay? And there'll be mild tachypnea as well. Overall, the child is usually very well looking, what we term as not septic looking, right? Now, have a listen to the next two videos. One is that of a barking cough, the next will be that of a stridor. It's very important to differentiate a stridor from a wheeze. A lot of the times, when the children present a little bit older age group, what happens in most of our casualties, our clinic kesehatan, is they think the child has a rhonchi, and they end up treating this child as a bronchiolitis or asthma and giving them recurrent salbutamol nebulizations, and the child just doesn't improve. Okay, so this video is of a barking cough. Have a listen. Okay, so this barking cough is a very harsh sounding cough. What they usually describe it in the literature is written as a seal-like bark. However, in my local setting, I will never ask the parents whether their cough sounds like a seal, because most of the population here in Sabah may not know what a seal is, or never heard a seal bark before. So I usually ask them, does the child's cough sound like a dog bark? And that's usually how they respond to saying yes to this sound. Okay, this next video is of a child who came in with croup, and this child is actually 3 months. Okay, the audio may be a little bit soft, but try to listen carefully to the sound. This is actually a stridor. right, so I hope you could hear that clearly. So this is a stridor. It's a very high-pitched sound, and it's produced because of turbulent flow through a partially obstructed large airway. Now, another point to note, look at how comfortable this child is. Although he's got some recession, he is a little bit tachypnic, but he's very well looking. In fact, if you have an older child with croup, they will probably be sitting up, playing with the mom while they're in distress. Okay? So this is what I mean by well looking. Now, if you proceed to do an X-ray, this is one of the classical signs you will see in croup. It may not be there in all patients, but what you get is what we call a steeple sign, right here. So this is a steeple of a church, and it's due to the narrowing of the airway at the larynx level. So if you have a noisy breathing, sounds like a stridor, the child looks well, you do an X-ray, you see this sign, your diagnosis is croup, okay? And you treat this child with a nebulized corticosteroid such as budesonide. Okay? So this management of croup is very well written in our pediatric protocol. Just open it up, you will have a flowchart on how to manage it. Let's move on to the next one. Epiglottitis. Now, this is a very life-threatening condition, right? It's an inflammation of the epiglottis and the adjacent supraglottic structures. Now, without treatment, an epiglottis can progress very fast to a life-threatening airway obstruction. And the presentation can be very similar to croup, but the child in this situation is generally ill-looking. Okay? Nowadays, it is relatively less common because of the Haemophilus influenza vaccination, which is the commonest cause for epiglottitis. Now, some of the clues to look for in this condition. The child has some sore throat history, and there's a thing, that's what they call the 3Ds. They present with dysphagia, drooling of saliva, and distress. Distress here, they tend to be in a thing called the tripod position, which I'll show you in the next slide. So when you have someone who you suspect has epiglottitis, now this child needs to be referred immediately to the nearest center with anesthetic backup, pediatrician, ENT, or surgical backup. You need to keep this child very calm. Do not do any unnecessary procedures or irritate the child, because the more you irritate them, the more distressed they become, and this child is usually very difficult to intubate. Okay, so we want to do it in a controlled environment, in OT with a video laryngoscope, under good gaseous sedation, and usually with an ENT surgeon on standby in case he needs an emergency tracheostomy. Now, this is quite a classical sign of someone who has epiglottitis. It's called a tripod position, where the child is leaning forward, the neck is hyperextended, and the chin is thrust forward. This is the child trying to maximize the patency of his airway, right? It's not only seen in epiglottitis, even in severe asthma, you can get this, okay? Because it's the same thing, there's obstruction to the airway. Now, the video I'm going to show you is actually a child with asthma, but he does have tripod positioning. So have a look. Right? So that's how they will be positioned themselves. So if you see this, with a child that has drooling of saliva, with a history that I mentioned, it's most likely epiglottitis until proven otherwise. Now, the other thing that they present with is what we call the sniffing position, okay? Where the child lifts his head a little bit, opens the mouth, keeps the mouth open to try and maximize the patency of the airway again. And they're usually very anxious children. Now have a look at this video. This is a direct laryngoscope of epiglottitis. Look how swollen the epiglottis is, right? And why we are very afraid when children present this way, because most of the time we may end up having problems trying to intubate if they need to be intubated in an emergency setting. Okay, so this is the epiglottis, extremely swollen. A very, very tiny opening here to try and get the ETT through, which is not easy if you don't have a video laryngoscope on standby. Right, so I hope you guys don't actually encounter this kind of patients, but you always have to keep this in mind, especially when you have patients who are not vaccinated or population where there are lacks of vaccination, like those with a lot of immigrant societies, poor societies, such as Sabah or some of the district rural areas in Semenanjung as well. Right, so the next cause for admissions can be foreign body aspiration. Now, this is commonly seen in those under 3 years old, usually peaks by age of 1 to 2 years. In infants and toddlers, usually it's a food item, nuts, seed, peas, right? Older children, you tend to get non-food items such as coins, clips, and toys, which are small and they're playing with it, pop into the mouth, and it gets lodged. Now, if it's a witness event, the parents saw it and they come in respiratory distress, the diagnosis is very easy. The parents will tell you they swallowed something and now they are in distress. The problem is when it's not witnessed. The parents did not see the event and it's not completely obstructing the airways. Now, these tend to present a little bit later and they tend to present with symptoms depending on where the location of the foreign body is, where it gets lodged. Okay? So usually if it's in the upper airway, the symptoms are more prominent, it's easier to diagnose. Now in the lower airways, this is when it frequently becomes misdiagnosed, especially if the X-ray is not radio opaque, it doesn't show up, foreign body is not radio opaque, it doesn't show up on X-ray, and it's not witnessed. So these patients tend to present with cough. They often get mistreated as asthma, a viral wheeze, or a pneumonia. Okay, so have a look at this diagram. This shows you where. So in the larynx, usually about 3% of the time. In the trachea, about 15%. Most of the time, if it is a small foreign body, it's going to go down into the lungs and it's going to be lodged somewhere in the bronchial system. And most of the time, about 60% is in the right lung due to the straighter airways, 23% in the left lung, and sometimes it can be bilateral if it's small things that have broken apart. So the classical triad of someone presenting with a foreign body of aspiration is a sudden onset and persistent cough with a localized rhonchi on auscultation. Usually in asthma, viral wheeze, it's bilateral. Okay? And focal reduction in air entry. But thing to note, that it's only present in about 50-60% of the cases. So whenever you have any one of these, you have to think in the back of your mind, especially if it's a small child, whether it's a foreign body aspiration. Now, if it's a foreign body that is radio opaque, no issues. Shoot an X-ray, you will automatically see the foreign body. Okay, the diagnosis, there's nothing in doubt here. Now have a look at this X-ray. You can't see any foreign bodies on this X-ray, but this X-ray has a very telltale sign of foreign body aspiration, which we call as a unilateral hyperinflation. Right. So the right lung here is very dark compared to the left side, right? And the ribs are well spaced out, so there's air trapping going on here. So when we have a patient with these X-ray findings, we usually have to look very hard for a foreign body and even refer over to our ENT colleagues to come and do a scope in OT to find if there's any foreign bodies lodged there. Okay, so let's move on to the next topic, which is acute bronchiolitis. Now, this is basically the bread and butter in pediatric acute admission wards, besides asthma and acute gastroenteritis. Okay, it's a viral infection. It's very common admission for those under 2 years old. It usually starts with a little bit of upper respiratory tract symptoms, cough, coryza. A mother will tell you 1 or 2 days, and then she'll start developing lower respiratory tract inflammation, leading to tachypnea and some noisy breathing. Usually when we auscultate, we will hear some rhonchi or crepitations, or a mixture of both. And again, although the child is in respiratory distress, they usually look well despite the distress. And it's commonly due to RSV virus, rhinovirus, adenovirus, and parainfluenza. So once you hit these viral seasons, you'll see a surge in admissions. Right, so let's look at some videos of some kids with bronchiolitis. Give you an idea of what I mean by they look relatively well. Right, so if you look at this last kid, he's got some quite moderate to deep recessions, but he's happily watching his baby shark, right? So that's a clue that it's probably a bronchiolitis instead of a pneumonia or a bacterial cause. Now let's go to the next one, which is also very common, asthma. Now this is one of the top 10 causes of disabilities in children aged 5 to 14 years old. And children with poor asthma control tend to have a very poor health outcome, impact quality of life. Schooling is often disrupted, they can't sleep very well, and sometimes it's very poorly controlled, can even lead to death. And it's got a very, very high prevalence, okay, about 7.1% in Malaysia. Now, it's a disease with many variations of phenotype, meaning they can present in a lot of different ways. It's characterized by chronic inflammation of the airways. Now, the two key defining features when it comes to asthma is history. A history of respiratory symptoms that are recurring and vary with severity or intensity over time. So sometimes it's mild, sometimes it's severe, but it keeps recurring, right? And there's a variable expiratory airflow limitations, meaning sometimes the child is not too distressed, quite well, just a little bit of cough, maybe a little bit of feeling of breathlessness. Sometimes it can be quite severe till they need to come to the hospital. So history taking is very important when it comes to diagnosing asthma. Now, if not in acute exacerbation, the physical findings can be normal. So this is when your history of symptoms comes in. However, if it's not too well controlled, what you can elicit sometimes on examination is what we call bronchi or forced expiration. So we make the child breathe out forcefully while we auscultate, and sometimes we can hear a little bit of a bronchi there. For older patients that come in with a suggestive history of asthma, respiratory symptoms, you hear bronchi, prolonged expiratory phase. And what I mean by older patients is usually around the age of 5 years old, because this is when it's quite easy and clear-cut to diagnose asthma. What you can do is you give them a trial of nebulized salbutamol or MDI salbutamol, and if they respond to it, this is a good indicator that you have the diagnosis of asthma clinched. Have a look at this next video. Right, the first video is the child when she presented to a clinic kesihatan. Right, she's in a lot of distress, a lot of recessions and retractions there. If you can look at the chest, it's a little bit hyperinflated, and she required some nasal prongs. Now I asked them to, although I couldn't auscultate this patient, the breathing is what we call a prolonged expiratory phase. She's breathing out very hard, right? So I told them to give this child a nab salbutamol. They gave 2 nab salbutamols, and next video is the child after the nab salbutamol. Completely comfortable, no more recessions, and chilling out. Okay, so this child, without a question of a doubt, has bronchial asthma. And we look back into the further history. She's been having recurrent cough symptoms, especially at night. She's got some reduced effort tolerance. When she runs, she feels a bit breathless in school. Right. So asthma is a very, very important topic. So please do read up a bit more in detail about asthma. You can always look into our Malaysian pediatric protocols. Another 2 guidelines that is great to look at is our Malaysian CPG for management of childhood asthma and the latest GINA guidelines, which was in 2020. Right? So all these are available as soft copies or hard copies. Go and have a read at this. If I give my housemates a case of asthma for their end of posting examination and they can't answer simple questions on asthma, it's usually a fail, no questions asked. If you cannot manage asthma, I cannot safely let you go out and practice in the district hospitals. Okay, now let's quickly go through some videos showing signs of severe respiratory distress. Now this child has head bobbing. Okay, have a look at it. The extension of the head and the neck during inhalation and falling forward of the head during exhalation. Now, when you see head bobbing in a child, this child is quite distressed. Okay, so we have to intervene a bit earlier before they go into respiratory failure. Now, I hope you can hear the sound in this video. Okay. If you can hear the sound clearly, this child is grunting. Okay. Grunting is a very, very important sign in pediatric patients with respiratory distress. If you hear this sound, this baby is trying to compensate very hard for his distress. If you don't intervene, he is going to collapse, right? It's basically the child breathing against a closed glottis. It's the body's attempt to keep the alveoli in the lungs open and maintain a peak, what you call peak end expiratory pressure, or maintain the functional residual capacity. And if you notice, this child also has very deep recessions. So this child most likely than not will require some sort of non-invasive or invasive ventilation. Now, this child has another very severe breathing pattern, what we call seesaw breathing. Okay? Again, when you see this child is in very severe distress. This child needs intubation. Another thing is, look how lethargic this child looks. He's basically falling asleep. This is not a good sign, right? He's got CNS depression. He's going into respiratory failure. He needs to be intubated, right? So I hope that just gives you a glimpse into some of the important signs and symptoms that you need to know for common respiratory problems. And now I'll move on to the second talk, since we were trying to catch up with a little bit of time so everyone can book up puasa later. Okay, let's go on to the road to pediatrics. Okay, so now when you talk about the road to pediatrics, I would like to say that the first step is the most difficult. And that first step is deciding whether you want to do pediatrics or not, right? And is it really for you? This is a very tough question to answer, especially, I guess, early on in your career. So a little bit of advice, I guess. As a medical student, what you can do to see if pediatrics is your thing is to do some attachments, right, in a pediatric department and see whether you like the work that is going on. In medical school, it's also a good time to see if it's something that you have interest in. If you ask me, I think for myself in medical school, it helped me decide what I don't like, but not really what I liked. Okay, this came later on. And when you're a houseman on your pediatric rotation, talk to your pediatric MOs, talk to your specialists about their work scope, see if it's something that you think you can do, right? Work as a houseman in a department, liking it is not the same as working as an MO or a specialist in the department. The stress level is a lot different, the workload is a lot different. Okay? And if you're unsure about the feel at the end of your housemanship, do not rush into a specific specialty. This is just my advice, yeah? Just because you feel you have to or your friends are doing it. Trust me, take your time, do something that maybe you can deal with a little bit of everything, such as clinic kesihatan, hospitals, district hospitals without specialists, right? And then you'll get an idea of where your interest lies and what you like to do. And do not be afraid to go to smaller district centers. A lot of my housemen say, oh, boss, very scared, I don't want to go to district. What if I cannot cope? But trust me, the experience you gain in a small center will be invaluable in your career. And it will help you decide where your interest lies, and it will mature you a lot faster. Now, once you have decided, that is when the journey begins in pediatrics. Okay. So let's talk about the latest system, which you guys will end up going through if you decide to do pediatrics. Right? So the latest system, as of 1st of March 2019, the Pediatric Parallel Pathway Training Program has been fully implemented. And this is overseen by Bahagian Perubatan Kementerian Kesihatan Malaysia. Now, the objective of this program is to allow for two comparable paths to pediatric specialization. Okay? As the master's program alone cannot cope to produce the number of pediatricians that the country actually needs. Now, the long-term goal is to have a single national pediatric training program and combine the two pathways into a seamless national curriculum where you can do whichever exam you want, but at the end of the day, you complete a similar program. Now, let's go into the program per se. To join or register for the Pediatric Parallel Training Program, you actually have to finish housemanship and be a medical officer first. That is the first requirement. Okay? So you can only register after you're a medical officer. Now, once you have become a medical officer, you can take one of two pathways. So that is why we call it a parallel pathway training. You can do an external paper, which is the MRCP-CH, which is what I did, right? So MRCP-CH, or you can do the master's program. Now, before you can register for a pediatric parallel training pathway, aside from being a medical officer, you will have to have passed at least one of the MRCP-CH theory papers. Either the part 1A, 1B, or 2A. You can do any one of these and pass one, plus you have to do 7 ELAs, okay, extended learning assessments, right? So these are basically 7 core basic topics which we believe that someone who is interested in pediatrics should know. Now, here's the good thing about the MRCPCH pathway. You can actually start it as a house officer, meaning you can take the Part 1 exams as a house officer. You can do your ELAs as a house officer. These ELAs can be taken by a pediatrician, family medicine specialist, or even an emergency physician, right? So you can do it while you're in the houseman rotations in this department. Then once you pass this, you've done all this, you become a medical officer, you can automatically register for the program. In the other part, the other arm is the master's program. So once you become a medical officer, only then can you apply to take the MEDEX, which is the medicine entrance exam. Right? You need 3 completed SKT years to apply for master's. Once you have passed the MEDEX exam, then you'll be called for an interview by the respective university. And if you're accepted into the master's program by the university, then you can join the pediatric parallel program pathway. Now, the goal for long term is to abolish this interview acceptance program so that you go take one paper, register for the pathway, and then KKM will assign you whether you go to a government training facility or university hospital. Now, once you have registered, if let's say you've gone into the parallel pathway of MRCPCH, then your training will start in an MRCPCH accredited training center. Okay, so you will be pulled into a pediatric department in an accredited center. Okay, be it whichever state, each state has accredited centers, and the training period is 4 to 7 years, minimum of 4 years. Okay, maximum you can take up to 7 years. Now, to pass the pathway, you have to pass all your MRCPCH exams, Part 1A, 1B, 2A, and 2B, which is the final clinical exam. And you have to fulfill all exit criteria. So the exit criteria here is a completion of a portfolio, which has multiple things that you have to do for the portfolio. And once you have done that, you are then undergo 6 months gazettement period and you're a pediatrician certified. Now, if you go into the master's pathway, so masters, you have 2 options, what we call the open or closed system. Closed system means all your years in training are in the university. Open system is where you do half of your training in KKM Master's Accredited Training Hospital, and then the second half or the first half in the university itself. Same thing, 4 to 7 years. To exit this pathway, you have to pass all the master's exam and fulfill all exit criteria, which is the portfolio. Plus for masters, you have the additional thesis, which you have to submit and pass as well. Once you've done that, then you undergo 6 months gazettement period and you are a pediatrician. So in the old pathway where we didn't have this minimum 4 years, we didn't have this portfolio and training program, our gazettement period was longer. So my gazettement period was a total of 18 months. Now, let's go a little bit into should you do pediatrics or not. Now, to me, pediatrics is one of the most holistic fields you can find. You not only have to manage the child, but you have to manage the child's family and sometimes the extended family members as well. Because a child's well-being or sickness or illness will always impact on the family. And vice versa is true. If they're having some problems in the family, it impacts on the child as well. And it can cause multiple problems, be it developmental delay, depression, and all that things, right? So we have to treat the child and the family as a whole. Now, is it a tough and exhausting field? Definitely. As you can see from multiple photos my friends have taken of me as a MO, falling asleep everywhere. Okay, I have literally fallen asleep on my feet during Passover rounds and almost fell over. So it is mentally, physically, and emotionally exhausting. Okay, imagine having to tell a parent that their child is dying or their baby is dying. Okay, is it fun? Definitely. We pediatricians and pediatric trainees never grow up lah. We are really kids at heart, and you will always have a very fun batch of people to work in the pediatric department. That's for sure. And now, is it rewarding? It is definitely one of the most rewarding fields to be in. To watch the smile on your patients' faces as they go home or even in the ward, and to see them grow up and out of their illness and become healthy grown adults. later on in life. So 1,000% yes to this, right? As a famous bear once said, sometimes the smallest things take up the most room in your heart, and it's very true in pediatrics. We all are very attached to our patients. We tend to try and keep them as long as we can. I know some of my consultants have their patients up to 22, 24 years old still under their follow-up, and their patients are coming in with their own children. Sometimes it's difficult to say who is the patient actually. Right, so to wrap things up, do come to work in Sabah. Okay, as you can see, these kind of sunsets are a very commonplace. Hashtag no filter for this. This is taken out of my ward window. Of course, I have to go back a bit late, so we see this quite often. And even better, come and work in pediatrics in Sabah. We really need more people working in Sabah, both as medical officers and pediatricians. Definitely need more pediatricians in Sabah. And I can guarantee you the experience you will gain here is priceless. And if you're Sabahan, even more so, please, Sabahan people, stop working, going to work in Tanjung and don't come here. Come back to your hometown. Right? So I'll end my presentation here. Thank you very much. And I'll take some questions if we have some time.
Okay, thank you, Dr. Dinesh, for this very informative talk. This talk has definitely broadened our perspective on a career in pediatrics, as well as improved our knowledge on the approach to respiratory distress in children, even at an undergraduate level. So before we continue, I would like to ask everyone to turn on their cameras right now for picture taking sessions. Ms. Sumitra, please stand by for the picture taking.
Sumitra is taking the picture, is it?
Yeah, I think
Okay.
she is.
So Elvin has been invited by Dinesh to go to Sabah, go back home.
Yes, please come in. I don't know why Sabahan, I only have one Sabahan pediatrician in my department, including consultant. Consultant and specialist, we only got one Sabahan, and we only have two Sabahan pediatric at most.
All of you, please on your camera just for 1 minute. We're just going to take the picture. After that, you can off it.
Sorry, sir, I don't see Sumitra.
Never mind, I'll take the pictures. No
so
issues.
I think, sir, is it okay if you have
Yeah, I'll take
picture?
it. I'll take it. The only thing is, a lot of people are camera shy suddenly. Just have to say it's a selfie, and they'll open the camera.
Okay, everyone, please on your cameras. Okay, Tarma said that he'll take the photo.
Okay, fine. So are we ready for the picture or how?
Tarma, on your count.
1, 2, 3.
Okay.
Oh, that's a sound.
1, 2, 3. Thank you.
Okay.
Okay, thank you, Mr. Tarma. So moving on, I'd like to pass the floor to Ms. Kanchana for the Q&A session.
Good evening, sir. Today I'll be conducting the Q&A session. We have compiled several questions from the participants. However, due to time constraint, we have narrowed it down to 3 questions, and the remaining will be sent to you through WhatsApp, sir. So the first question we have here today is, what are the challenges that you face day to day as a pediatrician?
Oh, that is a very difficult question because there's a lot. All right, I think what you will end up facing most of the time as a pediatrician, in all honesty, it's actually not dealing with the patient. It's always dealing with the parents. I find managing the parents to be the most challenging thing in pediatrics. The kids are very easy actually. They're unwell, they look unwell. Okay? And most of the time we have to manage the parents. The other thing that, of course, as you progress in your career in pediatrics, it gets a bit easier. But when you first start out, it's the procedures, right? Simple thing as doing a blood taking, which may be very easy when you're doing adult medicine. Pediatrics, it's a skill. right? It's something that the more you do it, the better you get at it. But of course, when you first start as a houseman, I don't expect you to be great at taking pediatric bloods, especially in small children, sick children, right? Even taking history or examining a children and pediatric population is, you need to be very flexible. It's a skill and an art that you learn over the years on how to get good at it. Okay? But for all these challenges, again, it's something that will get easier as time goes on. And of course, you learn how to play with the kids and be flexible when it comes to dealing with children, and more so than not dealing with parents. All honestly, that's my biggest headache all the time, dealing with the parents, never dealing with the child.
Okay, sir. So the next question is, what is the scope of being a neonatologist in Malaysia?
Okay, scope of being a neonatologist. Oh, good question, since that's probably what I'm going to go into. But all right. So actually, in whole of Malaysia, we're actually short of neonatologists. In fact, if you look at it, we are short of a lot of subspecialties for pediatrics in Malaysia, especially in government hospitals. Let me just give you a view in Sabah, right? So Sabah Dikas is the tertiary referral center for the entire state of Sabah, right? So we have a 96 bedded neonatal intensive care unit ranging from level 3 care all the way to level 1, and I have no neonatologists, right? And we cover the whole state. We have a visiting neonatologist, so we have to buy service from the neonatologist in private in Glen Eagles to come and do sessionals with us once a week. So we definitely need neonatologists. Even if you're thinking about going off to private later, it's also a good subspecialty now, because a lot of private centers are moving towards having a neonatologist to manage the deliveries that they're conducting there, right? So even if you say a delivery is low risk, I always say there's no low risk deliveries. You never know when a baby will come out flat, require resuscitation. So having a neonatologist is actually a good thing to have in a private center as well. So it is a good scope to go in. Of course, it's a very stressful thing dealing with neonates, won't lie, but I think any subspecialty will tell you the same.
Okay, doctor. So the last question we have here today is, what is the management of COVID-19 in children?
Okay, very long. Okay, so basically, I think the management of COVID-19 in children is still very much an evolving thing, because the studies are always done for adults first, and then once they clear the adult management, then they start to look into children. By and large, lucky for us, I guess, in a sense, we don't have as many cases as the adults. What I was telling Dr. Som earlier as well, it's roughly about 10% of the total adult numbers. Okay, so lucky in that sense, numbers are not very high. We don't see much severe COVID. By that being said, whenever we get hit by a very big wave, then we start getting a bit of illness. What we've noticed in the children is we tend to get more of the post-COVID inflammatory response, and that causes them to be very ill. During the active COVID, there are a little bit of cough, runny nose, maybe fever, but not that distress. But the post-COVID, what we call MISC, multi-system inflammatory syndrome of children, that can be quite bad. That we have had some patients requiring intubation, but we do have a number of cases in the district hospitals in the east coast of Sabah where they've ended up in active COVID and stage 5, stage 4, and end up dying. So it is potentially life-threatening, but not the bad COVIDs are not as bad. Generally, the COVID management is supportive. Okay? We only treat those who are ill, what we call the stage 4, stage 5. Then we give them treatment which consists of steroids, usually combined with antivirals therapy. But the only problem in children is whenever we have a child that's positive, although the parents may be more ill, they don't end up in the adult ward, they end up with us. Why? Because an adult center will never take any pediatric patients to their side. That's why I say kids are not little adults. You ask any physician to manage a pediatric patient, they will shake their head, cannot. I know no experience. right? So we no choice. We, like I said, manage holistically. I can't leave the child alone, so we have to manage the parents with the physician's input.
Okay, Doctor, thank you. So as of now, there are no questions from the YouTube live segment.